and good evening to all eminent faculty members and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Stephen Ansel from Mayo Clinic, USA, all discussants and participants to this virtual symposium on Nivolumab and Brentuximab based treatment of classic Hodgkin's lymphoma. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this continuous medical education series under the aegis of Mumbai Hematology Group, Dr. M.B. Agarwal. Sir is Professor and Head Department of Hematology, Bombay Hospital Institute of Medical Sciences, Mumbai. He is also associated with other esteemed institutes as well, like PD Hinduja Hospital, Leelavati Hospital, Fortis Hospital, and Breach Candy Hospital in Mumbai. He is the president of Mumbai Hematology Group as well. I request Sir to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Good evening to everybody from India, and good morning, good afternoon for the rest of the world. Today, our guest speaker is Dr. Stephen Ansel from Mayo Clinic, Rochester. He will be lecturing on Nivolumab and Brentuximab-based treatment of classical Hodgkin lymphoma, both newly diagnosed and in relapsed refractory setting. This webinar, as usual, is brought to you by Mumbai Hematology Group. It is supported by Zydus and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and team from Zydus, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, the most importantly, our guest speaker, Dr. Stephen Ansel, who has once again spared his valuable time to be with us. He is from Mayo Clinic, Rochester, US. All our discussants who are themselves eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening, morning, or afternoon. Tomorrow morning at 11:30 a.m. Indian Standard Time, I will be speaking on how do we use teclistamab for treating myeloma, the experience from India. Our discussants today are put up over here in alphabetical order. As you can see that there are very important persons with good experience in the field of Hodgkin lymphoma, and they are very keen to interact with our speaker today. Though Dr. Stephen Ansel has been with us multiple times in person and through the webinars, but I must complete the formalities of introducing him to those who have logged in for the first time. He is a consultant in the Division of Hematology, Department of Internal Medicine at Mayo Clinic, Rochester, Minnesota. He currently serves as a chair of the Division of Hematology and the Enterprise Deputy Director of the Mayo Clinic Cancer Center. He joined the staff of Mayo Clinic way back in 1999, and he holds the academic rank of Professor of Medicine, Mayo Clinic College of Medicine and Science. He earned his MB, CHB, and PhD degrees at the University of Pretoria in Pretoria, South Africa, where he also completed an internship in internal medicine and surgery, a residency in internal medicine, and a fellowship in medical oncology. He continued his education at University of the Witwatersrand in Johannesburg, where he was a registrar in internal medicine. He then came to the United States and completed a residency in internal medicine and then a fellowship in hematology oncology at Mayo Clinic. His research focuses on investigating the phenotype and activity of intratumoral T cells and developing strategies to modulate the immune function in lymphomas. He'll be lecturing us on Nivolumab and Brentuximab-based treatment of classical Hodgkin lymphoma, both newly diagnosed and relapsed refractory. Before I hand over the platform to him, I must tell you that he's keenly looking for the result of the Test match World Cup between his country and Australia, and there is probably just the formality to be completed before South Africa wins it. So he'll be delighted. And I'm sorry that we are keeping you away from watching that match. Okay.
Dr. Agarwal, thank you very much. Just to say, you are not keeping me away from that match because South Africa has already won. So,
Okay. Right.
well, I'm very grateful for the opportunity to participate. Thank you very much. And again, this is always a delight. Very grateful to be part of this. All right, All right, just wanted to check that the slides are visible.
Perfect, sir.
Thank you very much. So again, as you heard, thank you very much for being part of this program. I'll be talking about PD-1 blockade and Brentuximab vedotin, the CD30 antibody drug conjugate, and the basis of that in the treatment of classical Hodgkin lymphoma. As I start, I just need to disclose that my institution does receive funding for clinical trials, many of which are going to be pertinent to the discussion today. I personally do not receive any compensation. So I plan to talk about things in sort of 3 or 4 phases. The first is I just think we need to remind ourselves a little bit about the uniqueness of Hodgkin lymphoma and the pathology, the biology, the staging, just so we're all on the same page. I'm then going to talk about how to treat patients with early stage, limited and favorable disease, talk about patients with unfavorable disease, and then talk about advanced stage patients all in the front line. And then we'll talk a little bit more about patients who may relapse and how to manage patients with that circumstance. What you're seeing on this slide here is a little bit of pathology, just to remind you again about the pathology and the pathobiology of Hodgkin lymphoma. So the first thing to note on the top right is that this is a very unique disease in that the number of malignant Reed-Sternberg cells, you can see them arrowed there, is actually the minority, usually somewhere around 5 to 8% of the cells. And the vast majority, as shown on the upper left side, around that Reed-Sternberg cell, you can see the owl eyes Reed-Sternberg cell that you read about in medical school. But all those other cells that are around are actually healthy, normal immune cells that have been attracted there. The importance of that is that you really need an excisional biopsy when you diagnose classical Hodgkin lymphoma so that they can find those Reed-Sternberg cells. If you just aspirate cells, you may just get healthy cells. Shown on the bottom left is staining for CD30. So CD30 is the target of Brentuximab vedotin. We're going to be talking a lot about that. And you can see the CD30 positive Reed-Sternberg cells are pretty bright within the field of all of these normal cells. And shown on the bottom right is the amplification and copy number gain of chromosome 9p24.1, which is the locus for the PDL1 and PDL2 ligands which bind to PD1. And you can see right at the bottom, staining for PDL1 and PDL2 is very high on the Reed-Sternberg cells, again blocking the PDL1 and PD1 interaction very attractive as a treatment for patients with Hodgkin lymphoma. This schema just shows you that those cells are not just that we just discussed with all of these normal immune cells present around this Reed-Sternberg cell. They are not just simply sitting there. There is a lot of interaction that is happening between the Reed-Sternberg cell and the immune cells. And all of those present opportunities for disrupting this environment and thereby creating additional effective therapies. And we're really going to focus in on 2 of them, targeting the CD30 on the Reed-Sternberg cells and targeting the interaction between PD1 and PDL1L2 that is on the Reed-Sternberg cell as well. This is just some interesting data that I do think is valuable because it's sort of becoming a new standard. This was using circulating tumor DNA in Hodgkin lymphoma and identifying 3 patterns. Top left, you can see an immune inflammatory escape kind of picture. Top right, you can see data that would suggest there's a second picture which looks virally driven, mainly EBV. And then at the bottom, one that is driven predominantly by oncogenic mutations and really just a proliferative type of signature. And the reason this matters is that now looking at a large series of almost 250 Hodgkin patients, you can see that the outcomes, while they are good for most patients, are kind of different between the two. And I think what is the most interesting is the blue line, that is the lowest one, is actually the one that has this inflammatory immune escape phenotype, which again speaks to the fact that these novel agents may be most effective in that population of patients. And here is some data that would suggest why that might be. On the left, you can see now staining for MHC class 1 and class 2. Just reminding you again, why do you need MHC? MHC is the way in which the tumor antigens are exposed and shown to the immune system. MHC kind of forms a little cup, if you like. The antigen is placed in that, and in that context, T cells can see it really well. What you do note if you look at the panel there on the left side is that many of the patients that have Hodgkin lymphoma have downregulation, and most of them actually have loss of class 1 and class 2 molecules. Shown on the right is actually the fact that EBV may change and make that different. So loss of MHC class 1 or class 2 differs also by whether the tumor cells are EBV positive or negative. But regardless, the problem is that if you have downregulation of the way in which the immune system is supposed to see the cancer, clearly the efficacy of the immune system against the cancer may be compromised. And this really just shows how that may be true. So this is looking at, and we'll get to the treatment in just a minute, but these are patients in relapse setting receiving just nivolumab, but looking at it in the context of how much expression of MHC class 2 molecules there are. And the black line that you see at the top, particularly in panel C, are the patients that do best, and those are the patients where there is good expression compared to the other people at the bottom, which is where there is inferior expression of MHC class 2. So just the point being made here that besides the therapy you use, the context of the biology also matters. Here is data just to show that remember how I said amplification and copy number gain of chromosome 9p24.1 is one of the ways in which PD-L1 is highly expressed. You can see in panel C, the top two lines that have the best outcome in the relapse setting are those that actually have PD-L1 and PD-L2 and that is high due to amplification and copy number gain compared to those where it's just increased a little bit due to polysomy. What you're seeing in panel D is the level of expression of PD-L1. The higher the level, the better the outcome. One last thing just to say about biology as we think about these newer drugs and how they get incorporated into treatment. Many times we just think about the tumor cell, we think about the environment, we think about their interactions, but we forget that many of these proteins that we are interested in, that includes PD-L1 as I'll show here, but also includes CD30, are shed and are soluble and float around in the blood. And why that is important, here is data that we generated. If you look at the red dots you can see in Hodgkin patients compared to the blue, which are the controls in panel A, you can see much higher levels in the blood of PD-L1 and PD-L2 that is soluble. So it floats around, but you might say, well, who cares? Well, the reason that we care is that, as shown in panel B, if you stimulate T cells and then you add the soluble PD-L1 and PD-L2, it totally shuts down the T cells. So the effects of soluble PD-L1 and PD-L2 may be very important, not just in the tumor, but in the patient as a whole. And I would make the case that in CD30, the same is true, that if you have a lot of soluble CD30 floating around, it may act as a decoy for some of the Brentuximab vedotin treatments that we will talk about as well. The second thing I just wanted to take a minute about, just to get us all on the same page, is staging of patients. So the staging for early stage and advanced stage Hodgkin lymphoma. And again, within early stage, those that are favorable and those that are unfavorable. So here is a PET scan showing a patient with early stage disease, all on one side of the diaphragm, as you can see. But factors that can make this unfavorable is having a big mass, having disease that goes outside of the lymph node system, having high sedimentation rate, and also having multiple lymph node areas. So sometimes when we think about favorable, we just got to be a little careful that there aren't more than 3 lymph node sites because that actually would put patients in an unfavorable category. Here is the prognostic factor score for advanced stage patients. And you can see here that predominantly this has to do with the impact on the patient. So having stage 4 disease, but then mainly having blood counts that are out of the normal range. And that's really relevant because clearly now the disease is having its toll on the patient. All told, though, while we use this prognostic factor score somewhat, more important, as I'll talk about in just a minute, is PET scan response to therapy. And so while this is a prognostic score of interest, most of the time this is surpassed and overwhelmed, as it were, by the value of the PET scan for patients who respond. So now coming to therapy, just going to talk a little bit in general about the principles of treatment of Hodgkin lymphoma, and then talk about the specific data as it has evolved and where we are today. So again, as I mentioned, you have early stage disease and advanced stage disease. Within the early stage disease, favorable and unfavorable. So in essence, if you have favorable disease, you can use limited chemotherapy and low doses of radiation. If you have early stage disease but unfavorable characteristics, you will give more cycles of chemotherapy and greater radiation if you do combined modality therapy. As I'll show you, a number of studies have looked at omitting radiation therapy, and that is a strategy, but it does put a little bit of risk, and that's why I'll show you that the new drugs have really kind of begin to fill the space of possibly decreasing or omitting radiation therapy. If you then look at advanced stage patients, in general, the principles have been give more chemotherapy for more cycles of treatment and escalate the dose, particularly in high-risk patients. So how did we get to those principles? We're going to talk now specifically about early stage patients. And in early stage patients, really 3 trials have been informative, at least as we've initially tried to understand the value of giving radiation treatment. And I'll just briefly go through what each of these studies showed. The RAPID trial was from the UK and really asked the question, if you have 3 cycles of ABBD chemotherapy for early stage patients, do a PET scan. If the PET scan is negative, can you consider omitting the radiation therapy? The HD10 trial also followed a very similar fashion, but really asked the question is, should you just give standard treatment or should you use a PET-directed approach? And then HD16 really focused in on just the favorable patients and again asked the question about PET-directed and only giving involved field radiation therapy if PET positive. So here's the data that came from these trials. The RAPID trial asked the question, could you leave out radiation therapy? So give 3 cycles. If PET negative, no radiation, or compared to adding the radiation. And you can see in the PET negative patients, the outcomes for both arms were very good. However, there was a bit of a decrement in the outcome for the patients who omitted the radiation as far as progression-free survival is concerned. At the last ASH meeting, a 15-year follow-up of the study was presented and really showed that the overall survival was not compromised. So I think the sense here was that maybe you can omit radiation therapy, and even though little more patients may require additional therapy, that will not impact survival. I will tell you though, patients don't like to relapse though. So I think a comprehensive conversation about the decrease of about 5 or 6% really needs to be had with patients. The HD10 trial was actually regarded to be a negative trial, and you can see here the standard arm again received combined modality treatment. The investigational arm looked at omitting the radiation in the patients who were PET negative. And you can see there was a slight decrease in the outcomes of patients when radiation was omitted. In the patients that were in the favorable study for the HD16 German Hodgkin lymphoma study group, they also felt that if you only gave in the favorable patients 2 cycles of treatment and no radiation, you had, while a good outcome, you did have a significant decrement in the outcome. And you can see it didn't impact overall survival, but there certainly was a decrease, and that was felt to be a negative trial. One of the things that I think was very interesting from this study is what constitutes a negative PET scan. So if you look at panel A, this was if you did a PET scan and you regarded 1 and 2 as negative, those outcomes looked very similar. If you regarded 1, 2, and 3 as a negative scan, you could actually see that the outcomes got a little worse, suggesting that you really need to be convinced in your heart that there is no active disease. And if there are some, while we think of Deauville score 3 as negative, there's always a little bit of angst that there could be some cases in there that still have residual disease. Here's a lesson that we learned at Mayo Clinic. Right after that rapid trial came out, we basically embraced that and said, okay, we will, for negative PET scan patients that are with limited stage disease, we will omit radiation therapy. And then 8 years later, we went back and audited how we were doing. And you can see the combined modality treatment, those were the people before the rapid trial, compared to the ones where we gave chemo alone after the rapid trial. We found that our patients had deteriorated substantially, and there was probably at least a 15% worse outcome by omitting radiation. And we were a bit shocked by this. And the question was, why is that? So we had a look to see. And in general, we had not really followed the rapid rules quite the same. We had included some people who were a little bit more bulky. We included some people where the disease was kind of creeping out of the lymph nodes. And so the cautionary note here is, if you're going to omit radiation, be very sure that you have a relatively low risk patient. Otherwise, I think your outcomes are worse. So how are new drugs now starting to impact that? So the first way in which new drugs are being considered is, could you utilize these new agents, both nivolumab and brentuximab vedotin, as a way to limit or omit radiation treatment? And this is a study published now a year ago that really just showed that if you did AAVD chemotherapy, so brentuximab included into the first 3 cycles of treatment, for PET negative patients, switching then to nivolumab consolidation for 8 cycles, in PET positive patients using both of the new agents, both brentuximab and nivolumab for 4 cycles, and then going to consolidation. How did you do with this? And the outcome is really excellent. Most of the patients did not require treatment. 2 patients did progress out of an 83 patient cohort and required radiation, but everybody else did not. And after consolidation and completing all the treatment, patients generally remained in remission. The only caution I would say is that this adds a lot longer treatment to patients, and so this is something that hasn't quite become standard of care just yet. The German Hodgkin lymphoma group just simply said, well, could we just add nivolumab to AVD chemotherapy, either in a sequential fashion or in a concomitant fashion, but they still gave radiation at the end. The reason I just show this is I don't think you can improve on a Kaplan-Meier curve that looks this good. So certainly these results in more than 100 patients are outstanding. Finally, the question might be, again, leave out the radiation, add all the drugs together, but when you now think about the chemotherapy, only add the active drugs. So this is just doxorubicin and dacarbazine with nivolumab and brentuximab vedotin. And this was presented a year ago, but I think, again, the important thing here is a very high overall response rate and a very good progression-free survival curve. So if you were to say this was now the discussion of limited stage patients, do you need radiation therapy? Don't you need radiation therapy? Can PET-directed therapy guide you? I think PET-directed therapy is very feasible. It does impact therapy, but I would argue it maybe impacts it a little bit differently to how you might expect. I think if the PET scan is negative, just omitting radiation without careful thought can actually put you in a little bit more of a negative space with a poorer progression-free survival. I do think, though, PET positivity, escalating therapy there really makes a difference. So my view on this is, don't just simply omit radiation without caution, particularly bulky patients, poor prognostic factor patients. They need radiation therapy. And now with the use of proton beam radiation, or potentially utilizing novel agents instead of radiation, that may make the outcomes better. So what I hope you heard so far is, unique biology of the disease, staging is really important. Now we spoke about limited stage and the importance of really understanding risk factors to decide whether or not you want to add radiation therapy. But now we're going to move to advanced stage patients. So historically, we really had two strategies. And again, PET therapy was helpful, or PET scans were helpful to direct therapy. So the first strategy was start with a low intensity regimen like ABVD chemotherapy and crank it up if you find that the patients are not responding like you wish. The alternative was start with an intensive therapy kind of approach, like escalated BIACOP, and then you could decrease in patients who were doing well, and that way you could limit long-term toxicity. So how did we understand and develop this strategy, and how has it progressed to today? So again, three studies to talk about. The first was the English study, which is the RATHL trial. This was starting low. Started with ABVD chemotherapy. You received 2 cycles of treatment. If you were having a good response, you could drop the bleomycin. If you were having a not good response, you would escalate to escalate a BIACOP. The second study is the HD18 German Hodgkin lymphoma study. That was the opposite. That was if you start high with escalator BIACOP, you could decrease the number of cycles of treatment, not change the regimen, just give less of the regimen as a strategy. And the final one was kind of a mixture, which was again start high using escalator BIACOP, but if the patient is doing well, you could drop down to ABVD chemotherapy for the subsequent cycles. So how did this data show? What do the results show? The first is the RATHL trial. So again, this was where we started with ABVD chemotherapy. If after, at the time of the interim PET scan, you had had a good response and were PET negative, if you dropped the bleomycin, you could see that the outcome was not compromised. The PET positive patients, you could escalate the treatment to either escalated BIACOP or BIACOP 14. The problem there is if you look at those curves, I'm not exactly sure that it really brought up the curves as much as what we might have wished. The HD18 trial, as I mentioned, was the opposite strategy. Escalated BIACOP to start, and then if patients were doing well, you could decrease the number of cycles. So initially they were giving 8 cycles. They actually found that those were associated with a worse outcome with longer-term toxicity problems. But if you decrease to 6 cycles and even to 4 cycles, if patients were PET negative, you could get very, very good results and not compromise patients as far as toxicity or long-term complications was concerned. And then finally, the treatment where you started with escalated BIACOP and then decreased to ABVD chemotherapy, and you could see that both in the intent to treat and per protocol treatments, results were excellent. And so again, the same principle holds. If you start high and the patient's doing well, you can decrease to a less intensive therapy. But how could we improve upon that? And particularly when we're using an intensive treatment, how can we use novel agents to make the intensive treatment less toxic? And if you're using a less intensive treatment, how can you use novel agents to make the less intensive treatment more effective? So that's really kind of where the agents Brentuximab vedotin, which I'll talk about first, and Nivolumab have really come in. So you saw this picture on the right. This is the expression of CD30 on Reed-Sternberg cells. The image you see on the left, we're all very familiar with, is the antibody drug conjugate, Brentuximab vedotin, binds to the CD30, gets internalized, then basically binds to the tubulin, disrupts the ability of the cell to proliferate, and then causes the cell to die. And initially, this was tested as a single agent, but then combined with ABVD chemotherapy first and then AVD chemotherapy second. The reason I show this to you is just to remind you that Brentuximab vedotin and bleomycin don't really mix very well. A lot of lung toxicity came from that. So omitting bleomycin was critical to being able to move this regimen forward. When that happened, as you can see from the Kaplan-Meier curve, the response were very good and very durable. So that then was compared to the ABVD chemotherapy standard. As most of you know, this was in a randomized controlled fashion, 6 cycles of either brentuximab AVD chemotherapy or ABVD chemotherapy. And with longer term follow-up, it resulted in a better progression-free survival, and interestingly, subsequently, even in a better overall survival. Again, remember how we said that PET had really directed the therapy? This was not a PET-directed therapy. And so, in hindsight, went back to actually analyze by PET scan, did brentuximab vedotin addition make a difference? And you can see whether you were PET positive or PET negative at the interim stage. There was an additional benefit in both groups to brentuximab vedotin containing treatment over the standard. At the same time, the German Hodgkin lymphoma study group started working on modifying escalated BIACOP and changed it to BRIACAD. So most would know the treatment is built on this principle of the first shot is your strongest shot, so you want to keep intensive chemotherapy. So BRIACAD maintains the doxorubicin and the cyclophosphamide and the etoposide, which are felt to be the kind of powerhouse from the chemo side. But brentuximab vedotin is added to omit bleomycin and, in this case, to leave out vincristine, which causes neuropathy. Part of the problems with why long-term toxicities of both the bone marrow and fertility were a problem was the use of procarbazine, so that was traded out for dacarbazine. And then the second thing that I think was very valuable here is they used to give 2 weeks of prednisone, which had its own toxicity. That was shortened up to 4 days of dexamethasone. So that BRIACAD treatment was tested in a phase 2 fashion, was looking very promising, and then was compared in the HD21 trial, which was presented last year, in a randomized fashion. And the initial plan was just to show that it was equivalent. But as I'll show you in a minute, it was actually found to be more effective and less toxic. So here is the curve that shows that. You can see that the BRIACAD is the blue line at the top. The progression-free survival is superior to escalated BIACOP, but very importantly, better tolerated. Still does have some toxicities, but better tolerated. This study also was a PET-directed study, so patients who are PET negative may only require 4 cycles of BRIACAD and get the excellent result that you see from the blue curve in this study. And I think the reason that is highly important is that really this treatment is done in approximately 3 months. Changing gears now a little bit, so you heard about targeting CD30 and making ABVD and escalated BIACOP better, so that we now have found that the BRIACAD and the brentuximab AVD regimens are kind of more standard. Now just switching gears and looking at PD-1 blockade and showing again, as I've mentioned earlier, that targeting this amplification and copy number gain was very effective in the relapse setting, and then that also moved to frontline. So this is the original phase 1/2 study of the use of nivolumab plus AVD chemotherapy in frontline, very high response rate, while the follow-up here was kind of on the short side, but you can see the progression-free survival was actually very excellent. So similar to the brentuximab vedotin trial, this was again a randomized trial, 1-to-1 in for 6 cycles. It was nivolumab AVD chemotherapy, now being compared to the new standard, which was brentuximab AVD chemotherapy. And you can see a few things that were unique about this trial. This trial actually included pediatric patients from age 12 and also went to patients over the age of 60, which often in the escalated BIACOP studies had not been possible because of toxicity. Secondly, because the treatments are relatively well tolerated, particularly nivolumab not causing much hematological toxicity, you can see that in that arm, GCSF was actually optional. And these data show that nivolumab AVD chemotherapy showed a significant improvement in progression-free survival over brentuximab AVD chemotherapy, and that was published last year. And you can see that with 2-year follow-up, that appears to be holding up. What I think is very interesting about this study is that you can see that in elderly patients, that's patients over 60, this was a particularly effective regimen, nivolumab AVD being better tolerated and more effective because patients tolerated well compared to brentuximab AVD chemotherapy. And similarly, in the pediatric patients where other regimens are very commonly being used, this was a very effective regimen and was superior to brentuximab AVD treatment. So similar to what I mentioned in limited stage, how about we just take all of this in the way of therapies, put them all together and see whether or not that's more effective. So here I would just highlight that advanced stage patients treated with brentuximab vedotin plus nivolumab and then the two most effective drugs, doxorubicin and dacarbazine. This is not a large study. This is just a phase 2 study, so we'll need a randomized trial. But you can see the overall response rates are very high and the progression-free survival looks good. But to know if that's better than, for example, nivolumab AVD chemotherapy will require a randomized comparison. So what do I think is my takeaway and my choice for treatment as the primary frontline treatment for Hodgkin lymphoma? I stress here that this is outside of a clinical trial. I'm a big fan of patients participating in a clinical trial. I think if you have very early stage disease and favorable characteristics, the standard of treatment there is 2 cycles of ABVD chemotherapy and 20 gray of involved field radiation treatment. Note, if you drop the radiation in this case, the outcomes are worse. If you have early stage disease and favorable and you're PET negative, you can leave out the radiation treatment. I would particularly consider that in a non-bulky patient or a patient where radiation may occur to the breast or the heart and relatively low burden of disease. However, if there is larger masses, more extensive disease, personally, I would add in radiation therapy. And then in advanced stage disease, I think particularly in elderly patients, in low-risk patients, a standard of care is the nivolumab AVD chemotherapy. I think in the higher risk patients, the data for Briacad looks outstanding. So now with the last few minutes, going to change gears and talk about salvage treatment and relapse disease. And this is one disease where transplantation remains very central. And so when patients relapse, I think the key question in one's mind needs to be transplant eligible, yes, or transplant eligible, no. Transplant eligible, yes, the goal is to give salvage treatment and move to an autologous transplant and potentially consider consolidation thereafter. In contrast, if you're not thinking about that, then you're playing the long game and you want to make sure then that you're using more single agents and more palliative approaches and adding radiation to get the best result possible. So I want to show you 2 salvage regimens that just need to be considered. Both of them contain a PD-1 blocking antibody, and the reason for that I'll show you in a slide that's coming up. So this is the pembrolizumab plus GVD chemotherapy regimen. This was a small study of 40 patients. Overall response rates were fantastic, 100%, and the CR rate of 95%, which for relapse patients was almost unheard of, and everybody was able to go on to an autologous transplant. Similarly, the use of ICE chemotherapy in many rare places is a standard. This is the addition of nivolumab to ICE chemotherapy. And again, you can see a high response rate and a high CR rate, and most patients able to go on to receive an autologous transplant. So why is that important? This is a large cohort of multi-center study across the US of people that received in the blue line a immune checkpoint therapy before going to transplant plus the chemotherapy. In the black line, a brentuximab vedotin plus chemotherapy, and in the green line, chemotherapy without either of the new agents added. But I think what's notable here is that adding an immune checkpoint agent to the combination as part of the salvage treatment appears to be making a substantial difference. And so therefore, I think that's an important piece of information. Have to acknowledge this is retrospective multi-center analysis, not a randomized trial, but I think at this point a randomized trial is probably not coming. This just is older data, but I think this older data is now coming back into the picture because as we're using more immune checkpoint therapy in frontline, fewer of the patients have received brentuximab vedotin. So you might remember that before anybody had received brentuximab vedotin until they relapsed, this was the Athera trial looking at giving brentuximab vedotin compared to no therapy post-transplant as consolidation. And the benefit in these higher risk patients who were either refractory or had relapsed early or had relapsed with disease outside of the lymph nodes, you can see in every group there was benefit to adding brentuximab vedotin. So in our practice, where we're using more PD-1 blocking antibodies in frontline and or in salvage, we're actually using a lot more brentuximab vedotin post-transplant as part of the maintenance therapy as per the Athera trial. And then finally, just to remind you that when you have patients who relapse even after an autologous transplant, I'm not going to spend a lot of time today talking about other options. I'm sure the discussants may be able to talk about that. But the important thing here is if you have not received pembrolizumab or a PD-1 blocking antibody, or you've not received brentuximab vedotin and have had a transplant, there has been a study comparing those two agents in the relapsed and refractory setting. And what you can see here is that PD-1 blocking antibodies appear to be better as far as progression-free survival is concerned to brentuximab vedotin. However, I would point out that nowadays most people have received something, either one of the PD-1 blocking antibodies or a brentuximab vedotin. So this data are a little bit more difficult to interpret based on what's been given earlier in the lines of therapy. So what do I hope you have heard a little bit here related to relapsed Hodgkin lymphoma? What are some of the principles I think one can take away? What's the preferred salvage before you go to a transplant? In our practice, we use a lot of ICE chemotherapy, and now we add nivolumab to that, but pembro GVD would be very reasonable. But as I point in the second bullet point here is, if you haven't received a PD-1 antibody in frontline, I definitely think you should receive it as part of your salvage treatment before you go to transplant. What is the role of consolidation post-transplant? Didn't show a lot of data around PD-1 blocking antibodies after a transplant. There are only 2 small studies that suggest that's beneficial, but there's no randomized comparison like there is for brentuximab vedotin. Also, many people are receiving PD-1 antibodies in frontline, so we are tending now to favor brentuximab vedotin post-transplant as consolidation. And then which drug should you use at consolidation if one of those has been given before the transplant? My view is that if you have failed either brentuximab or a PD-1 antibody, I don't think there's evidence to say that using those as consolidation does much good. And I would omit that because I think you bring toxicity without benefit. So, summarizing all of this before we have our discussion, just to highlight, the Reed-Sternberg cell is the target. You can see on the top left brentuximab vedotin. You can see on the top right PD-1 blocking antibodies. But the reason I show you this is just there are multiple other ways to target these Reed-Sternberg cells, a number of which are now being used in the subsequent lines of therapy. So with that, I'm really grateful for this conversation. Going to finalize discussions that I think are takeaways for this meeting. Include new drugs in initial therapy. Brentuximab vedotin plus PD-1 blockade, both of them have been shown to be beneficial. I think if you're using AVD chemotherapy, a PD-1 blocking antibody is required. If you're thinking about an escalated BIACOP, the BRIA-CAD regimen is superior, so I think that's the way to go. When you get to relapse patients, if the patient hasn't received a PD-1 antibody, they should receive that as part of the salvage treatment. If they haven't received brentuximab vedotin, they should consider that post-transplant. And then clinical trials remain important because we still want to cure 100% of patients, and we have work to do. So with that, I'll end. I'll thank you very much for your time and attention, and I appreciate being part of this meeting.
Thank you so much, sir, Dr. Ansel. This was a wonderful discussion, wonderful presentation. You made both brentuximab and PD-1 inhibitor role very, very clear in both upfront and relapse setting. So good number of friends are around. They will like to ask you some question. We start with Dr. Raghuveer Prabhu.
Muted, sir.
Muted.
Thank you, Dr. Ansel, for that wonderful talk. I just have a query, like you mentioned about soluble PD-L1 receptors. So is there any correlation between PD-L1 expression on the Reed-Sternberg cell and the soluble PD-L1 levels?
Yeah, that's a good question. And to the best of my knowledge, no one has actually looked at that specifically to correlate it. And part of it is just because the expression is actually very high on the Reed-Sternberg cells. So I guess it's, high and higher. And so I think, and also responses are very good to treatment regardless of expression. So I don't think there's been a lot of reasons to do that. So your good question is one that I don't have a good answer to.
Thank you. Thank you.
Thank you, Raghuveer. Dr. Ashok.
Good evening, Dr. Ansel. And I have a question regarding a patient which I am treating, a case of a relapsed refractory Hodgkin's lymphoma, who was upfront because of a stage 4B disease, upfront treated with pembrolizumab and AVD. And he had a 22 months of a PFS, followed by a relapse. Since he was earlier treated with a Pembro AVD, so he's treated with the Nivolumab and GDP regime. And however, this patient is again shows a progressive disease in a PET scan. Now we started him on a Brentuximab and a THAP regime, and now just waiting for a PET scan after 2 more cycles. So what should be a better approach for this type of patients?
No, I think all of the treatments you've given to date are very appropriate, and I think that's very reasonable. My hope would be that the patient will benefit from the salvage treatment that you're giving right now. And if so, I would then proceed to an autologous transplant and consider brentuximab consolidation post-transplant. I will say this much. There are some folks who really want to have patients be in a CR before they go to an autologous transplant. My personal view is that I don't think that's necessary, especially in a patient like the one you're describing, where it's been hard to get them into a good remission. I think if you've got them moving in the right direction, I would proceed to a transplant if you can.
So if he will not be in remission after another cycle, should you indicate that to add a new brentuximab plus some salvage therapy for this patient before going for autologous?
So if he's even if he's in a partial remission, I would proceed to an autologous transplant. If he's had no response, or heaven forbid, he's actually progressing, I would need to switch to a different salvage regimen. We sometimes will use bendamustine plus brentuximab, for example. That would be another alternative to consider.
Thank you. So in the era of all these agents, what's the place of allotransplant?
Yeah, so Dr. Agarwal, that's a very good question. And it's been funny if you look back, not funny, it's kind of sad in some respects, but it's been interesting, shall I say, how things have varied over time. So there was a time when everybody felt like if you gave any degree of response post on autologous transplant with like PD-1, you should go to allo. Then we got some really good results with the PD-1 and we said, well, maybe we don't need an allo. Then we found the people started relapsing and then we were back to, yep, we probably need an allo. I think, to be very honest, in our practice, if you have a young patient who understands the risks, allo still has a role, because particularly now with the post-transplant Cytoxan, which minimizes some of the side effects, the outcomes are actually looking better with allogeneic transplant, and we will certainly consider it in post-transplant, post-autologous stem cell transplant failed patients.
Right. Thank you, sir. Dr. Satish.
Thank you, sir. Thank you, Dr. Ansel, for that crisp presentation, and your guidelines were very useful. So have you moved out of ABVD completely now? You give only Nivo AVD or BV-AVD for Hodgkin's lymphoma?
No, so I think there's still a room for ABVD chemotherapy, particularly in early stage patients, because if you look at our data right now, around, moving to Nivo-AVD, there's very limited data in early stage patients. There are some trials in progress right now. I would say personally, if you have an early stage patient, you gave them ABVD, 2 cycles, they got a good response, you drop the bleomycin, you can actually get very nice results for maybe 2 more cycles, and that would be very legitimate treatment. And so in resource restricted areas, I think ABVD chemotherapy still has a role, particularly, as I say, in early stage patients.
And in advanced stage, do you prefer BRICAD or Nivo-AVD or BV-AVD?
So I think there's a lot of it is about the support that you feel your institution can bring. So BRICAD, while less toxic than escalated BIACOP, still requires you to have pretty strong resources to support your patient. So if you have those, and particularly in my view, if you have high risk disease, I think that's a very legitimate way to go. If you're in a more kind of, it's difficult to have, the patient come in the middle of the night and those kinds of things, the Nivo-AVD treatment is better tolerated, and especially if your patient is older.
Thank you, Dr. Ansel. One more question. Should we give BV consolidation for all those high-risk groups of Hodgkin's lymphoma post-transplant for 16 cycles, like for 12 months, or can we cut down on that?
Yeah, so very interesting. If you go back and look at the echelon trial, the Athera trial very closely, you'll see that actually the average number of cycles, if my memory serves me right, was like 9. So not too many people were getting 16 because of the neuropathy. So I think if you're giving somewhere around 8 to 10 cycles post-transplant, which is pretty much like about 8 or 9 months, you're probably fine, because the data would say that's when you can expect the same results.
One last question, sorry. Post-ABVD in a advanced Hodgkin's lymphoma, if the patient relapses, do you prefer Nivolumab-based salvage or BV-based salvage?
Yeah, so I would say that, again, based on the data that says the outcome looks better if you use a PD-1 antibody before you go to transplant, we would typically use either Pembro GVD or Nivo ICE. And interestingly, again, this is not based in fact, this is my best guess. I think the reason that is true is because the PD-1 antibody stays in your blood probably at least another 2 or 3 months through the transplant process. So when you go through the transplant, you beat everything down, and then the bone marrow comes back up again, the PD-1 blocking antibody protects the fresh T cells and allows them to be more effective. So that's why I think the PD-1 antibody is helping in the transplant setting if you give it before.
And there is no need for consolidation with PD-1 antibody post-transplant. There is no data for that.
Well, there are 2 small studies that have looked at that. Both of them were positive, but I have to point out that both studies were around 30 patients. So again, I don't think that that's something we have enough data to say that that's better than using Brentuximab consolidation.
Thank you so much, sir. Thank you.
Thank you. Dr. Ashok again.
Sir, regarding a patient of a relapsed refractory Hodgkin's lymphoma who are undergoing allogenic stem cell transplantation and who received PD-1 inhibitors prior. So, regarding risk of GVHD in these patients who received prior PD-1 inhibitors and undergoing allogenic transplant, I just want your comments about this.
Yeah, so again, very good question. We are a little bit cautious about giving PD-1 blocking antibodies too close to an allo transplant. And there are good data. Again, the data are really retrospective and multi-institutional, but it does show that if you are a little too close, you can actually end up getting more problems with graft versus host disease, more toxicities. So in our practice, we try and avoid giving you a PD-1 antibody 8 weeks before you get your allo transplant, as a way to try and mitigate that. We're also finding now that actually most people have got the PD-1 antibody well before that, and we're actually doing other things to get them in remission before the allo. So it's actually becoming less of a problem because we've kind of given up on PD-1 blocking antibodies much earlier. But if they are on it on the way to an allo, we try and stop 8 weeks ahead of time.
Thank you, sir. Thank you very much.
From the chat box, there are many questions related to combining Nivo with Brentuximab or Pembro with Brentuximab, either in a newly diagnosed patient or in relapse setting. What is your opinion, and will that be the future?
So I will say I think the future is definitely going to be using these agents together. My view is that it's not one or, you can use both and get better results. At this point, I don't think we have data to say that it's a good strategy to use the combination in frontline. I think we have much better data around using one of the regimens, specifically, either Nivo-AVD or Briacad as frontline therapy. However, I think in the salvage setting and beyond, very reasonable. We will often use BV-Nivo as a combination and then go to an autologous transplant. So that's also a very legitimate kind of strategy. Depends a little bit on availability of agents and approvals and that sort of thing.
Thank you. Dr. Devaranjani?
Thank you, sir. So that was a lovely talk. Sir, I need opinion on two questions which I have. First is, how do you tackle brentuximab associated neuropathy? Because for many of our patients, beyond 4 cycles of brentuximab, with whether it is brentuximab AVD, brentuximab GDP, we encounter a significant amount of neuropathy, peripheral neuropathy, sometimes painful in these patients. So do you have to stop brentuximab ever because of neuropathies?
Yeah, so that actually is a very significant and very real problem. And I think it's often underappreciated and often under inquired about. So people don't ask, doctors don't ask patients, do you have that problem? Because you're dead right. The neuropathy is very uncomfortable and it takes a long time to go away. So I do think it's very important to anticipate it, ask questions about it. If it's becoming a problem, I think it's very important to weigh up the merits of keeping the brentuximab going versus the need, obviously, for avoiding the neuropathy. So for us in our practices, we generally find people start to get real challenges with that somewhere around 6 to 8 rounds of treatment, and so often need to stop. So we try very much to avoid the neuropathy by cutting down on the dose and extending the time. Typically, I've found cutting the dose is a better way than extending the time, because once the neuropathy is kicking in, you can extend the time all you want. That neuropathy is not going to change.
Thank you, sir. Sir, I have one more question. I had a young lady, 27-year-old lady, who was diagnosed with classical Hodgkin's lymphoma. She had an advanced disease, stage 4 disease. So, because of constrained resources, initially we started off with ABVD. She progressed after 2 cycles of ABVD on the PET. So, we put her on Biacop. We found some government funding, so we were able to give her Biacop. We gave her 2 cycles of Biacop, following which she again progressed. We had an access to compassionate access brentuximab, thankfully. So we gave her 2 cycles of BV-GDP. After BV-GDP, she again progressed. 2 cycles. So then we resorted to Nivolumab. We gave her Nivo Ice, 2 cycles. Following which her PET came in CMR. So we gave 2 more cycles of Nivo Ice, a total of 4 cycles of Nivo Ice. And then now we have decided to take her up for direct allogenic transplant. She only has a half-match sister. So we have planned to take her up for haploidentical transplant with her sister, given that she has failed 4 lines of therapy. Sir, your opinion on this, and would you do anything differently?
No, I think that's very reasonable. This is a pretty resistant, nasty disease. I always encourage people, when it's not behaving like you expect, always biopsy again, just to make sure you've not got something like a large cell lymphoma or something that's in there that is a little bit of a different biology than what you're thinking. But regardless, I think that's very legitimate and very reasonable. A case could be made for trying an autologous transplant first, but I think in a multiply relapsed patient like this, you probably only got 1 shot, and so I wouldn't really have any critique.
Thank you, sir.
Thank you. A question from the chat box. Dr. Mehak wants to know, when you have used Nivo-AVD for a newly diagnosed patient, do you use PET2 based response adaptation?
So I think the answer is no. When you're using Nivo-AVD, I think you're just going to go with 6 cycles. I will say this much, I still do an interim PET scan, just because I like to know personally that things are heading in the right direction. I'm expecting a very good improvement. I don't insist that it has to be ice cold negative, but I'd like to know that it's going in the right direction. So that's the reason for doing that, but I don't adjust the treatment based on that. The only time I would adjust the treatment is if there was evidence of progression. Typically, I will rebiopsy and then switch treatment to a totally different regimen at that point.
Thank you. Another question is, from your talk, it appears that if you have a young patient with very high volume disease, you will go for Brecard. An elderly person with low volume advanced disease, you will go with Nivo-based treatment. Is that correct?
So I think that's still got some additional nuance. So I think those are principles which I think are accurate. I will say this much, that in some of even in some of the higher risk patients, my colleagues in my practice will all do Nivo AVD. I think there's a large enthusiasm because of the ease of administering it. But I think what I'd love to see is it better than Brecard? And we don't know that. The data for Brecard are really stellar. So that's the reason, again, if I really have a lot of concern, I personally do tend in high-risk patients, especially younger high-risk patients, favor Brecard.
Thank you. Question from Dr. Aishwarya Raj is, any experience with low-dose Nivo?
Yeah, that's actually a really good question. I mean, basically, nivolumab dosing, there hasn't really been a comprehensive study as to how much you really need. And so, we've found that you can stretch the time between the doses quite a long way. You can decrease the dose and still get good results. So I think when you're in a either too much toxicity or resource constrained, it's worth ensuring that you use the least you need. I will say, though, in general, we like to start at the regular dose and get a good result. Then you can cut down dose or cut down time, depending on what you want to do.
Thank you. Dr. Mehak wants to know, do you encounter late onset or chronic toxicities of Nivo, like adrenal insufficiency or thyroiditis? How long do you monitor these patients?
So the answer is yes and yes. We get long-term toxicities. Yes, we get thyroiditis. Yes, we get adrenal insufficiency. So that is something to watch for. If my memory serves me correctly, in most of the trials, somewhere around 15% or even more of the patients ended up with hypothyroidism. So I think very important to actually be monitoring for that. And that is long term. So again, watching for it and ensuring that you're managing it is really important. And then, just being vigilant for symptoms that don't fit, and then think about the fact that there could be endocrinopathies is really important.
Thank you. In a patient who is not fit for autologous transplant, what will be your preferred regime when the patient relapses?
Yeah, so I think the key question there is, when you say not fit for transplant, it's how fit is not fit. If it's just a case of the person could tolerate other chemo type treatments, just not a transplant, that's an opportunity. But on the flip side, if the person is really frail, that's different as well. I will say this much, that we have found that using immune checkpoints on a long-term basis to maintain the benefit as long as possible, or doing BV plus Nivo together as a kind of a longer-term strategy, those are ways to control the disease. Sometimes we'll use bendamustine alone in those patients, but the goal now is not to cure the disease. The goal is to control it. So we're using lower doses, stretched out as much as possible, minimizing toxicity.
Thank you. Another question is, advanced stage disease in elderly person with ejection fraction of 20%. What's your protocol?
Yeah, so again, this is one of those places where you need to make a decision about, are you still trying to cure the patient versus, just control the disease. In general, obviously, omitting the adriamycin is kind of the plan. And so you can pick a regimen that you feel can omit that. And now that BV and Nivo and other agents are available, we will typically put those in the place of it. So agents such as COP treatment or CHEOP treatment or those kind of things have been what we've used in the past, and then we'll often add nivolumab or pembrolizumab to that as frontline treatment. We're kind of making a little bit of it up at this point. We can also, consider a mini CHOP, but then add Nivo as a strategy, because CHOP chemotherapy is also still being a very effective therapy for Hodgkin lymphoma, even though it's a non-Hodgkin regimen. And then we just omit the doxorubicin.
Thank you, sir. Dr. Christopher wants to know, should a patient treated with Nivo AVD in the front line responded well, now relapses, will you re-challenge with Nivo with some other chemo combination, or should we consider BV?
So I think in general, it all comes down to how quickly from the previous treatment the patient relapsed. So if the patient relapsed kind of like while on the treatment or within, let's say, 6 months after that, I would call that patient having a refractoriness to a PD-1 antibody and would not use a PD-1 antibody subsequently. If a year or two has gone by, then I don't think that's the same. And then I think I would add in a PD-1 blocking antibody, because remember, adding that before transplant really seems to make a difference.
Thank you. He also wants to know, can we re-challenge with Nivo in a patient who has developed inflammatory combination?
So yes, you can. I mean, you can do, and I think the most important thing is just how desperately sick was somebody if they had an inflammatory kind of problem at the first place. If it was moderate and you could control it with steroids and a little break in the treatment has resolved it, I think it's quite okay then to re-challenge cautiously, and usually that's maybe better tolerated, and you can well use some steroids because it doesn't really dampen the effect unduly. If the patient had a life-threatening event, I would consider something different.
Thank you. The question from Dr. Thant. You have a CD30 positive, CD15 negative, ALK negative lymphoma, which is PAX5 negative and GATA3 focal positive. Will you treat this as Hodgkin?
So that's a little tricky, because it's, I'm listening carefully for all the magic numbers there to make sure I got it right. That sounds to me like it's either a T-cell lymphoma or it's a anaplastic large cell lymphoma. So I would be a little cautious to treat it like Hodgkin lymphoma. I think that's a patient best treated with BV chip. Again, if you really was to say you'd be covering a multitude of sins there, you'd be covering the possible for a T cell, you'd be covering some of the possibilities for some kind of large cell, and then also you'd be covering Hodgkin lymphoma. But the main thing I would argue there is a phone call to your pathologist to say, I need a little more definitive diagnosis here, young man.
Right. Question from her again. Any washout period required before doing an autologous transplant?
No, again, it actually might be beneficial, particularly for PD-1 blocking antibodies, for there still be some of it around, because it may actually help the reconstitution of the immune system.
Right, that's the last question in the chat box. Any question from here? So none. So in that case, Dr. Ansel, thank you so much. It was wonderful.
Really appreciate it.
To you, and then this long QA session, we really enjoyed it. And you have been always with us. Every few months we keep bothering you. Thank you, really, really thank you.
Okay.
Bye-bye.
Well, thanks everybody. Have a great evening.
Bye.
Bye-bye.
I must ask if our sponsors are around. Yes, Mr.
Yes.
Yes.
Thank you, Dr. Ansel, for sparing your valuable time. It was a very lucid presentation with the brevity in communication, and it was followed by a very, very engaging discussion. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion and navigating this entire webinar in a highly proficient manner. I also thank all the discussants and participants who have joined us for this webinar. Last but not the least, This series of webinar is possible only because of continuous support from Perfect Square team. So thank you to them as well. Thank you so much, everybody. Have a wonderful weekend.
Thank you, Mr. Sumit. Bye-bye.
Thank you, sir.